Great. Well, welcome. This evening, we're going to be speaking about women's health issues and really about women's health in general, a few different topics. I'd like to spend a fair amount of time this evening talking about perimenopause and menopause. So as we go through the evening, my name is Brad Jacobs. I'm a physician. I run a practice called Blue Wave Medicine at Cavallo Point Lodge. We do these lectures every month, once a month for the most part. And we have different speakers, often myself, and many times we try and bring in guest speakers as well. So this month, I'll be speaking about women's health. But let me give you a little backdrop here, just to let you know what we do overall and what we'll be doing tonight. So as I mentioned, I'm a medical doc, and I run an integrative medicine, primary care, concierge medicine practice at Cavallo Point. So we work with a nice team of practitioners, and you can get more details on the website, Blue Wave Medicine, if you're interested. We cover a huge range of topics in the practice as well as in our talks. So these Tuesdays to Your Health talks are held monthly, and we cover brain health, gut health, women's health, men's health, conversations around fitness and conversations around longevity, stress, anxiety, sleep. So we really try and touch on a lot of the main topics that affect all of us through our lives. So thanks for spending some time with us tonight. I know we're competing with the Los Angeles Dodgers versus the San Francisco Giants game playoffs. So hopefully for those that are interested, started about a half hour ago, and you can watch it delayed if needed. We'll also post this lecture, like we always do, on our YouTube channel, which is Dr. Brad Jacobs, DR for Dr. Brad Jacobs on the YouTube channel. So if you know folks that can't make it this evening, just direct them to the YouTube channel and they can see it. Usually by the weekend, we'll have it posted. So let me share my slides, and if you don't mind, just give me a little bit of feedback if you don't see the slides in presentation views, because sometimes it doesn't show it appropriately. And if you do have questions as we go through the evening, please don't hesitate to go in the Q&A box and just add a question in that I'm happy to cover. It's hard to cover everything, and all of us have different ideas of what we'd like to necessarily cover. So feel free to reach out as we talk, or if I didn't clarify something, I'm happy to do that a little bit better. So hopefully this here is in presentation mode for you, and you should be able to see that clearly. So let me know if that's a problem, but otherwise I'll presume you can. So again, as I mentioned, I run a practice called Blue Wave Medicine, and I'm also involved in an organization called the Academy for Integrative Health and Medicine. And I bring that up just because it's worth knowing about this organization, which is really focused on helping practitioners of all disciplines really learn integrative medicine and become quite conversant in it. There are people also that are not health professionals, but are deeply interested in the field of integrative medicine, and they also have a membership in this organization. We have a conference actually upcoming that'll be virtual at the end of this month. So if you're interested, it's worth looking at aihm.org for the Academy for Integrative Health and Medicine.org. There's about 20,000 people involved in this community. It's a global community, although there's a big influence here in the United States. So, so moving on to sort of what we'll cover this evening. So we'll speak a little bit about PMS, and then really a fair amount of time around perimenopause and menopause and its influences around all these other aspects that we have listed here. And so I'll go through what people can experience only to normalize that experience for many of us or many women that feel like they're the only one experiencing whatever they're experiencing. So the intention is to normalize that for you. And then in the second half to talk about what can you do about these different aspects to help improve your quality of life. So just to lay out a bit of a foundation around what happens with hormones over the course of a woman's life. So as you can see here, the purple is estrogen, and the dotted line in orange is progesterone. And in the fertility years, you can see that both are quite predominant. You know, after puberty, they both shoot up, they stay quite high. And then as you move into perimenopause, you can see that what starts to happen here is that progesterone starts to wane. And then you start getting undulations in the amount of estrogen that's around as you enter into menopause. And then finally, it drops to when you're postmenopausal, your estrogen levels drop and your progesterone remains low. In a different view on that, sort of a close-up view, you can see here estrogen and progesterone, and that relationship is an important relationship. You can see progesterone drops fairly precipitously, and estrogen, while it also drops less precipitously, and there tends to be in many women estrogen dominance, and the progesterone is less. And we'll talk about what that means, but you can see there's this gap here. So women that live their, predominant part of their life before perimenopause with an estrogen dominance are more likely to have fibroids, endometriosis, polycystic ovary syndrome, breast cysts, more likely to have PMS symptoms, menstrual cramping, and then also these menopausal symptoms, which we'll speak into. And some of the causes of this dominance of estrogen really relate to lifestyle. So you can see there's a huge piece around stress, and particularly around diet, excess sugars and carbohydrates. You know, I have a teenage daughter who I'm trying to always tell, do your best to really reduce your carbs and sugars. Of course, her immediate response back to me is, A, I don't know what I'm talking about because I'm a guy, and B, that she's like, that I crave that so much right before I'm having my period is sugars and carbs. And so you have this sort of struggle, that internal struggle that women have, but we do know that PMS symptoms are worsened with eating excess carbs and sugars. So other nutritional aspects of, overall weight gain overall, so increased caloric intake in particular, and then environmental aspects. So if you have estrogens that are coming from other places, whether it's hormone fed into animals that we then eat, or if it's coming from exposures of xenoestrogens like plastics, et cetera, that sort of act like they have behavior like estrogens, that can lead to this estrogen dominance. So of course in addition, if you're being given extra estrogen, of course, that'll lead to that as well. So how to think about reducing that? Obviously, it's the opposite of some of the things we just said. Avoiding hormone-fed animals if you're eating animal product, avoiding plastics, or cooking in plastics in particular, and also really modulating stress, and as well as diet, or with carbohydrate and sugar intake. So nutrients that are used that can be quite effective, particularly with women in PMS, but also in other aspects of people with different health issues related to estrogen dominance, include these. So you've got trimethylglycines, you have vitamin B6 and B12 and folate, bioflavonoids, which are abundant in vegetables. You also have NAC and acetylcysteine. Probiotics can also help by helping modulate estrogen elimination through the gastrointestinal tract. And things like indole 3-carbinol, you may have heard of, or I3C or DIM. These are related to cruciferous vegetables, actually, and they are extracted out from that, and then you can take it as a pill, for example, which actually will modulate the metabolic byproducts of estrogen metabolism, these what we call 2-hydroxy or TOH, and then 16-hydroxy or 16-OH levels. So we'll modulate those so that they're more beneficial, reducing breast cancer risk as well. So what are some herbs? Some of you have heard of a lot of these before. Chaste tree, which is often used for PMS, for example. Black cohosh, which is often used in hot flashes. Rhodiola, which is what we call an adaptogen, which is very nutritive as well, and has wonderful effects both on mood as well as its energy levels. Dandelion root, which is often used for liver metabolism, to improve liver metabolism. It's also good for the GI tract. And licorice and rhubarb. Siberian rhubarb, people have heard about for menopause as well, for hot flashes. So let's talk about perimenopause a little bit to provide a little bit more of a definition about what it really means. I mean, so if you think about parameter or peris around menopause, meaning you're not quite in menopause, but you're starting to have some symptoms. So this is a transition period. And for many women, it may start in the early 40s. So a lot of, and historically, it was very much poo-pooed, like people are feeling more anxious or they're sleeping less and they're feeling more irritable in their sleep, or they're having more obvious things such as hair thinning or skin dryness, or obviously hot flashes, or just not quite even a hot flash, but just they're feeling shifts in their body temperature. And all of those and others symptoms can be related, early sort of prognostic signs of people going through perimenopause. Doesn't mean they're going to be in menopause, and this could last for years. A matter of fact, on average, it lasts 4 years. But don't be surprised if you or your friends, if you notice that these sorts of symptoms are happening. And most doctors will poo-poo it as, oh, you're having anxiety, you're having insomnia, and don't think about the hormone part of the equation. The obvious other parts are if your menstrual cycle starts to shift as well, right? Sometimes it becomes shorter, sometimes it becomes longer, sometimes it becomes lighter. It's really, I think it's important to be on the lookout for this. Vaginal dryness, I have listed here, though, that often is further down in the spectrum or the sort of journey, if you will, of modulation of hormones. Further down, it takes longer really for vaginal dryness for most women to take place as it relates to shifts at the vaginal wall as it relates to reduction in estrogen in particular. So I take this from other folks that have spoken into this. I think it might have originally come out of the New York Times, but the 7 dwarfs of menopause. So there you have them: itchy, bitchy, sweaty, sleepy, bloated, forgetful, and psycho. So obviously these are exaggerations, but metaphor oftentimes can sort of bring out some of the qualities and context of what we're trying to understand. So keeping that in mind, just to think about menopause itself, on average for women, menopause occurs on average in around age 51. But there's a huge spectrum, right, from 40 to 58. And if you think about it, 50% of American women were in menopause in 2015. So clearly, this is not a rare phenomenon. It's a normal part of the life journey. It's not a disease. This is part of one's life journey. And by definition, menopause is the absence of having menstrual periods for greater than 12 months. So why do we care what happens to us or to women in particular? So symptoms of menopause, you can see they're all over, right? Every organ's affected, going from the head all the way down. And the reason is because there's estrogen receptors throughout the body. So from the joints, back pain, urinary, skin, breasts, even palpitations, psychological, transitional, vaginal. So looking at, let's just start with these, and we'll sort of move through each one of these buckets and then come back around and talk about the different therapeutic options. Sweaty and sleepy. So these vasomotor symptoms where people get hot flashes, they may get night sweats, which is this dysregulation of the hypothalamic temperature axis. And there's this cute, cartoon here, another hot flash, huh? So you can see here, and while we're making fun of it, women can really suffer deeply from this. It can really disrupt sleep from the night sweats and the hot flashes. They find themselves comfortable, and all of a sudden they have a wave of sweat or a wave of heat and turning flushed, and they're really trying to modulate. So lots of times you'll find women layering their clothing, layering their beddings, etc. Their partner is not experiencing that perhaps, and so they're experiencing the sheets uncovering and coming back on, and uncovering, coming back on. Windows are open, windows are closed, etc. So what about the psychological aspects? There's really 2 to 3 times more chance of depression during menopause. And like we mentioned before, the estrogen dominance can actually really increase some of the anxiety, irritability that occurs. And we see these changes in our hormone also called DHEA, which is a sex hormone. So there's a lot of psychological aspects, particularly irritability, particularly anxiety, as well as depression. And that's so just to normalize that, and then to think about what can you do, whether there's self-care aspects, whether there's supplements, or whether there's hormone replacement. And then, then only then would you consider antidepressants or anti-anxiety medication, right? It's important to sort of walk through all the other options that are available to you that may be addressing the underlying source issue rather than just the external issue of saying, let's do an SSRI. Bloating for many women, so they can get a 10% increase in abdominal fat, increase around 5 pounds on average. And again, this sort of high estradiol levels prior to low levels. So you can see this big shift in hormones, and particularly estrogen hormone. And then what tends to happen is progesterone shunts to cortisol with stress. So when women are under stress, you get this conversion of progesterone moving to cortisol. Cortisol then leads to weight gain as you're under stress, as it relates to insulin conversion. And then as you have more insulin resistance, for example, which leads to more weight gain, and it becomes a negative cycle like that. So itchy, that relates to really to dry skin. And again, related to hormone changes. And you get this increased ratio of androgen, the male hormone, testosterone, to estrogen, simply because estrogen is dropping. So relative to androgen, you get this change in this ratio. You can lead to vaginal atrophy, and also on the skin itself, external skin, loss of collagen leading to more wrinkling, hair loss or excessive thinning, female pattern hair loss. Some women can get dry eyes, and a higher prevalence of cataracts as it relates to these hormone changes. Droopy and toothy. So really there's this decline in bone mineral density as it relates to hormones. And as you know, many of you have probably heard, this was a predominant driver for the use of hormone replacement therapy back in the 80s and 90s as it related to heart disease prevention, as it was thought back then, as well as bone mineral density. And bone mineral density, there's about a 10% reduction during menopause. And most in the year before and 2 years after menopause. And as it relates to tooth loss as well, gum changes and thinning, periodontal disease due to inflammation. And then sexuality is a big component that was really under-discussed early on in the 80s and 90s, but really people are much more comfortable speaking about it. And I encourage you, if you experience any of this, to really speak about it with your health professionals that you work with. Women are 2 to 3 times more likely to have a decline in their sex drive with age, and a lot of it relates to having painful intercourse, a reduction in really interest and libido, and really as it relates to the painful intercourse, is because there's reduced blood flow to the vaginal wall, and there's reduction in sensitivity as well. So there's less pleasure experience, and also can be more painful because there's less lubrication. So as it relates to memory, women are 2 times as likely in general to get Alzheimer's. In part, it's really a lifespan bias, meaning that women tend to live longer as well. So that partly influences increased risk. But estrogen does drive glucose metabolism in the brain. So as estrogen drops, glucose metabolism, the use of fuel, glucose to fuel the cell, it reduces. So there are shifts in brain chemistry as the estrogen levels change. And low estrogen levels in the brain cause it more of a hypometabolic state. So we do see there's a lot of research going on, particularly out of Cornell, looking at menopause and cognitive changes. Doing very sophisticated studies, using PET scans and functional MRI scans. It's really quite interesting. So if you look at here, neurologic functions affected by the perimenopausal transition, you can see here some of these changes sort of mapped up, where you can see executive function and working memory. You can see the estrogen receptor alpha and estrogen receptor beta, ER alpha and beta, in the front part of there, that's called the prefrontal cortex. And then, for example, if you look down here in the posterior cingulate, which is where the default mode network is, the working memory and task preparation. So the default mode network is an area where we actually scan for threats. We look for, and there can be an area where people then that start to worry or ruminate. This area can be much more activated in this overall default mode network, which is actually a full network through the brain, one of the main areas being the posterior cingulate. But you can see here, there's an estrogen receptor beta located there, and on and on. So the hippocampus, where we consolidate memory, you can see estrogen receptor alpha, beta as well, and many other locations. The amygdala, which is the emotional center. So as these levels decline, then you get shifts in these neurologic areas. So, as it relates to the hypothalamus, which I think is right here, you can see here, regulation of temperature. We think that may be related to the hot flashes and night sweats that people experience, that women experience. And sleep, the suprachiasmatic nucleus as well, affecting sleep. That's the area that controls sleep as well. So that's why we may see a lot of these changes. So women aren't, some women say I'm going crazy or I'm losing my memory. A lot of this happens as there's these modulations and changes in estrogen. And for that reason, I'll just say right now that I'm a big proponent of estrogen replacement therapy. Because it's been shown to be quite safe in my experience and in the research that I've looked at when prepared in the modern form, unlike the previous form which was prepared from pregnant horses and taking their urine and using the estrogen from a pregnant mare, a pregnant horse, taken from their urine, and then put a very high dose and given to humans. To give to women. That's very different than how we do it now, which is considered bioidentical, made either from a pharmaceutical drug company or compounded. Nonetheless, it's all taken from the same source, including the compounded pharmacies. They take it from these compounded pharmacies that using a natural bioidentical hormone replacement by cream is really the same source as an estradiol powder that they're getting from a pharmaceutical drug company that then they put into a cream. Or you could buy it through the regular pharmacies, conventional pharmacies, commercial pharmacies, and that comes as a pill or as a patch, or even as a intravaginal ring. So we'll talk more about that a little bit later. So what can we do about this? And maybe I'll pause if there's any questions that have come up that I haven't addressed around just sort of laying out the landscape of some of the symptoms that women can experience and why you experience these symptoms. So I'll keep moving forward then. So what are some remedies? So I like to really bucket these into lifestyle is one area. Herbal or dietary supplements is another bucket. Hormones, so whether it's bioidentical that I just spoke about or synthetic, hormone replacement therapy. And as I mentioned, there's what we call it we'll get more detail on what that really means, synthetic versus bioidentical, because they're not really mutually exclusive. Acupuncture, and then other devices that are out there as well. So let's speak to some of the herbs and start with that. So, before we go there, actually, let me just say about lifestyle. So a foundation, as an integrative medicine physician, and I'm trained in a lot of different areas, so all the areas listed here, and more. And I'll say that what's foundational to our quality of life across all health issues and health aspirations is self-care and is lifestyle. So many of us in the Bay Area are fully aware of this. It's a question of whether or not we can actually operationalize it and bring it into our life and create habits that are positive for us around it. And I'll just say in brief that if you can find time to move your body 15 minutes a day, if you can find time to reduce the total calories you're eating and minimize the amount of carbohydrates you take of those calories, and if you can find time to reduce your stress by walking in nature, maybe you're exercising in nature, going for a walk on the trails throughout the Bay Area, or maybe you can also meditate. Meditation really needs to just be done a few minutes. Ideally, people do it 3 times a day, and they'll do it for 3 minutes each time. That will really allow you to keep it fresh and keep it very in front view for you. A lot of people try and sit and meditate for 20 minutes and 15 minutes or even longer, an hour, and people get very agitated and uncomfortable, and they get bored, and then they feel bad because they think they don't know how to meditate, and then they're a horrible person, and there's all this self-loathing and all this judgment. And what I find to be way more effective, in speaking to a lot of senior teachers about this that meditate, that are monks, is that do a very short amount of time. Just do it for 3 minutes. Set a timer for 3 minutes. And if you do it 2 or 3 times a day, what you'll find is meditating 3 minutes, 2 or 3 times a day, is that's a controlled experiment 3 times a day. And so what tends to happen is you are focusing, let's say, on your breath for 3 minutes. And then you're noticing, thoughts come through, and you notice your thoughts, and then you just, oh, I'm thinking, you realize all of a sudden you're thinking, and then you come back to your breath again. And you do that over and over again, over a 3-minute period of time. And then while you're living the rest of your day, then noontime comes around, you do it again for 3 minutes. And then, you're going to do it again around 4:30, let's say in the afternoon, and around 3 o'clock, you notice yourself daydreaming, right? You're doing something, but you find yourself daydreaming, or you find yourself getting agitated about something or excited about something. And what tends to happen is you start to notice that more, because you're running these short experiments for 3 minutes where you're noticing it. So all of a sudden, 5th day of doing this, you've done it 12 times in the past 4 days or 5 days. Throughout the day, you'll start to notice yourself and becoming more aware of yourself and how you're running your operating system, how you're running yourself through the day. And it becomes a beautiful, really, tapestry of being able to witness yourself in real time, in real motion. And all of a sudden, that journey becomes a very deep internal journey where your stress starts to shift, and you find it very rewarding, and there's a lot of flourishing that happens. So I encourage really very light, small doses of meditation. No reason to go sit for 3 hours and torture yourself. All right, so on to herbal remedies. So black cohosh, many of you have heard of this, I'm sure. It's quite safe. It's found to be quite effective for many women, but not all women. And it's dosed really twice a day, often 40 milligrams twice a day. It's really predominantly for hot flashes, but also used in combination sometimes for women experiencing mood swings and sleep. Siberian rhubarb has also been found to be quite effective for hot flashes in particular. It's also looked at for mood disturbances, and that can be quite effective as well, Siberian rhubarb. St. John's wort obviously has been used mostly for mood, and the good thing about it is it can be quite effective for mild to moderate mood, predominantly depression. But it does interact with the medication. So it's important to make sure to see what medications you're on and make sure there won't be an interaction between this herb and other medications. And then dong quai has been looked at also for menstrual migraines, as well as for hot flashes. There's a combination that people have used with soy, black cohosh, and dong quai, looking at for menstrual migraines in particular. That's noteworthy. And then valerian, particularly for sleep, has been shown to be quite effective. There's lots of different herbs available for sleep and supplements and nutrients, but this is one I thought that's worth thinking about. In addition, hops is helpful, and red clover for hot flashes has been looked at. Some trials have shown it not effective, red clover. Others have been shown it to be effective. Hops as well, particularly it makes people sleepy. And it's helpful for sleep as well. So, and what about thinking about vaginal dryness? So there's lots of different suppositories that are available. People have used vitamin E. People have used coconut oil in particular is quite good. And people have done laser treatment. There's these DHEA ovules. There's sort of suppositories that you can insert up made with DHEA. And so there's, I think it's called Intra Rosa, if my memory is correct. And that's really a DHEA, plant-based DHEA product that's inserted intravaginally, and then kudzu as well, and then estrogen itself using either, there's something called the fem ring, there's a lot of different, basically, hormones that are placed inside either a ring or a cream or a suppository that you place in the vaginal vault and allowed to stay there. The E ring, for example, is left for 90 days, but other ones are placed up and used twice a week, for example, such as creams. And those all have been shown to be helpful for vaginal dryness to varying degrees. And I'll get into a little bit more detail around this as well further down. So there's been a couple questions about estrogen. So one person mentioned they have a blood clotting disorder, and they've been always told don't use hormone replacement therapy, and asking whether or not bioidenticals are safe. And then someone else asked, how do you feel about bioidentical hormones, breast cancer that's activated by estrogen? I think the question relates to, bioidentical hormones in the context of breast cancer risk. So we'll speak to both of those. Let's just talk about the pros and cons here. So the pros around estrogen replacement, obviously a lot of the symptoms, every symptom basically that we've mentioned can be managed by estrogen replacement for obvious reasons. That's the predominant issue, is that estrogen starts waning. If you replace the estrogen, the symptoms get better. There is some data showing that while the early research, the Women's Health Study showed that might increase fat cardiovascular risk. Actually, there's early data showing that it may reduce cardiovascular risk as well as dementia risk. Now, what are some of the cons? As several of the people in this conversation we're having together have already identified, increased risk of blood clots, increased risk of stroke risk, increased risk, gallstone risk potentially, and breast cancer risk. So the question is how much of an increase in risk, and is it real? The current calculations that we use takes into account the three categories. Are you at increased risk for blood clots? And if you are, we typically recommend that you don't do hormone replacement therapy, to answer your question. And the reason is because it further increases your risk of blood clots. So depending on what kind of blood clotting disorder you have, if you have a significant one that has a real increased risk, then we typically counsel women away from using hormone replacement therapy, because we don't want to, God forbid, increase the chance that you then have a clot in your leg, or God forbid into your lungs. That would be something that could be quite damaging, and then you have to go on long-term anticoagulation, etc. The cancer risk is sort of mixed. There's certain data that shows that there's increased cancer risk, in particular when estrogen is used with progesterone combined. Estrogen alone, there might be a reduction in cancer risk, actually. Some of this data is still forthcoming, but it's definitely mixed. So we typically run a breast cancer risk protocol or calculator algorithm where we'll ask a series of different questions to determine what's your lifetime breast cancer risk. And based on that, we'll determine whether or not you're a candidate for hormone replacement therapy. So those are really the factors, and it's really a straight up calculation. We also look at cardiovascular risk as well, although we think the data shows it's actually beneficial, but we do also include that. So if someone has a very high cardiovascular risk, we'll often counsel them away from doing hormone replacement therapy. So this is a straight up calculation to answer one of your questions here, looking at breast cancer, for example. You drop it into the calculator, and if it shows that you're at high risk, the answer is no. If it's sort of in the gray zone, then it's a conversation of what tolerance you're willing to have. Many women, their quality of life is really dramatically shifted from menopause, and they're willing to take the slight theoretical increased risk. And others say that they're not willing to. So it's really a conversation with your health professional. So what we tend to do is for most women is just use the lowest dose for the shortest possible time. Meaning that there's two ways in medicine, you know. Some people in medicine start the highest dose and then reduce it over time. And in this case, we do the opposite. We start at the lowest dose and slowly increase over time and see what kind of benefits you're getting from that. And most women, honestly, once they're on it, don't want to come off. So while, you know, for litigation and liability concerns, people say the shortest amount of time because they're lowest dose for shortest amount of time because that's sort of the most conservative view, meaning we're going to limit your exposure to hormones. And typically we say you need to start it within 10 years of being postmenopausal, ideally within the first 2 years, actually, and that you shouldn't be on it beyond 10 years. You shouldn't be on hormone replacement therapy beyond 10 years. Many women I know stay on it and just continue on because they so appreciate the benefits. So everyone has their own risk tolerance, and it's really an ongoing dialogue with your health professional. So the conversation around synthetic or bioidentical hormones is really to sort of look at the conversation that truly, unless it's a plant-based hormone, which we try and do, for example, people do with yam, for example. And when you talk about estrogen, there's really subtypes of estrogen. There's estrone, estradiol, and estriol. The predominant one we often use is estradiol, which as you can see here written out. It's really synthesized. And so while people call it bioidentical, we're calling that now because it's really, the predominant receptor that we have in our body enjoys the estradiol. In the vaginal vault, in the vagina, often it actually uses both estradiol and estriol in particular. So you'll find these estriol creams or a cream that has estradiol and estriol in it, both in the vaginal area. So it's a bit of a marketing, in my view, a bit of a marketing scam, because the compounding pharmacies are calling theirs bioidentical and natural, but it literally is coming from the same source. It's coming from a pharmaceutical drug company that comes in a white powder of this estradiol, and then they mix it using emollients into a cream that then they sell. Versus the commercial pharmacies make it into a patch, or actually they don't make it into a patch. It's made that way in the pharmaceutical drug company, then delivered to the pharmacy, then dispenses it. But it's really the same source compound. The advantages of the compounding pharmacy is you can really titrate the dosing, much more nuanced. You can also combine it. You can have a cream that has estrogen and progesterone in it, or you can have different types of estrogen in it, like I mentioned before, in that one cream. Some people also react, they don't like the patch. They have a reaction to the patch, so they don't want to use it, or it's not affordable for them, so then they're using the pill and they don't like what's in the pill. So there's other reasons why people will choose compounded version, but there's really very little difference other than that. And often insurance companies will pay for the patches. So that's a summary slide, really, what we're talking about here, the synthetic. The other synthetic are the old types, right? Like I mentioned earlier, these horse-based estrogens, which obviously we're not using anymore. And then you have within the concept of progesterone, which is the bottom half of this 2x2, you can see here that the methoxyprogesterone acetate, which is what we used to use back in the earlier studies, caused coronary artery spasm, lowered HDL, which is the good cholesterol, it lowered that, clearly was toxic to the body. So unfortunately, women were being given, like in my mom's era, were being given this form on the left-hand side of this 2x2. Now we give women on the right-hand side that the progesterone is a permetrium, which is a micronized version, which has a much better cardiovascular profile and is much better tolerated. And that can be given as a pill. And the beautiful thing of the oral version versus a topical cream, for example, progesterone, that you might get compounded at a pharmacy, is the oral version is far more sedated. So women that are having difficulty with sleep due to hot flashes or irritability or other areas, as we mentioned earlier, in the brain, the area that affects sleep gets messed up as well because the estrogen receptors there are starved for estrogen. By giving progesterone, it improves people's sleep quality. And by giving it as Prometrium, which is this what we call micronized version of progesterone. So I think for the most part, we covered most of this. So I'll just sort of let you glance through this slide. So here's some examples in case, we talked about some of these already, but I'll just mention them again. The patches I've been talking about, or like the Vavel dot is a patch, Chimera is a patch. There's lots of different patches, Allura, Estroderm. And then you've got the pills and creams that might be, for example, like Estrace, and then estradiol acetate, which is like as a fem ring. So that would be a vaginal insert. You'd insert that in the vagina. It's a ring, and you push it up deep into the vagina, and it stays there for 90 days. Women love that because a lot of people react to the patch, or it just gets irritation, from replacing the patch. You replace it twice a week. And so the fem ring, once you figure out the right dosing, which I typically would have women start with a patch so we can modulate dose so we get the right dosing, and then do that dose as a fem ring. And then you don't have to change it. It's in there for 3 weeks. Some women notice that towards the tail end of those 90 days, they need a little bit more supplementation of estrogen. So they might add on a patch in addition to that fem ring on the last 2 weeks of that 90-day cycle, just to give a little more estrogen on the backside of that, of using the fem ring or any other sort of a vaginal ring like the Eastern. Progesterone, these are FDA approved. So like I mentioned already, the Prometrium is the one that I would recommend. So we think, as I mentioned already, the compounded or the estradiol-based, patched, even commercial-based bioidentical hormones, we think it actually may have proved out projectively when it's done without progesterone, just estrogen by itself, that it may lower breast cancer risk, heart disease risk, and blood clots. That it's actually the progesterone itself that's increasing risk around blood clots and increasing our risk around breast cancer. So, and actually it's more effective in improving mood. And you can see all these studies here. So why not do it without progesterone? The reason is, although some women do this, the reason is that you're at risk for uterine cancer. So what happens is with estrogen is building, and so you build more and more thickening and thickening of the uterine lining. That could lead to uterine cancer. So the progesterone allows the sloughing to take place, which allows for a menstrual period. So when you do the estrogen and progesterone, if you do a low dose daily of the progesterone throughout the month, then you tend not to have a full sloughing, but it keeps that at a certain thickness, which is the correct normal anatomic thickness. Women can also cycle progesterone, and if you cycle it, then when you come off it, you would then have a period. But the reason you can't just do estrogen is at risk for uterine cancer. Of course, if you don't have a uterus, if for some reason you had a hysterectomy, then women just use estrogen, what we call unopposed estrogen. Some women will do transvaginal ultrasounds every 3 or 6 months and screen to look for thickening of the lining, and just do unopposed estrogen. But in general, we tend to shy away from that recommendation. So as I mentioned about progesterone, it's very calming. It can be used as a sleep aid. Good data on safety versus the old school synthetic progesterones that they used to use. And as I mentioned earlier, the Provera confers a slightly increased risk of breast cancer, this progesterone aspect. A lot of times we're been talking concerned about estrogen, but it's really the progesterone that turns out to be the problem, we think. So here are all the different formulations you'll get. Oral, cream, sublingual, atrocious, really comes in many different sorts. The compounded types you can see here, where you can mix all these different types of estrogens together into different ratios. So there's lots of different options. Each one of these can be done in different ways, right? So there's a lot of, and it's really an art. When you work with most people, it's really an art to figure out what's best for you. It really is, it happens over time. So acupuncture has also been shown to be really helpful for hot flashes in particular, as well as sleep, quality of sleep, mood, anxiety, really improving quality of life. So typically we recommend people experiment with that. Typically it would be weekly for 4 weeks and see if they see a benefit. And if they do, then you continue on with that. Supplements to think about for bone health outside of estrogen and SERMs are vitamin K2, calcium, but limited amount of calcium. Too much calcium will increase your risk of heart disease. Vitamin D as well as this combination, as well as obviously strength training and exercise. So sources through our food supply for vitamin K, you can see here, and just, so here's just a cute little comic. I read it can cause low blood pressure, dizzy spells, and fainting. News, Viagra for women, but not one word about causing headaches. So what's the issue really around sexuality and libido with women? So for many women, as I mentioned earlier, there's many reasons why libido is reduced. Partly it's directly hormonal in the brain. Partly it relates to vaginal suppleness, and partly it relates to reduced sensitivity. So there's lots of different reasons. So women that still want to have an active sex life will look for other things. And here's some examples of what's possible. So in addition to lifestyle on the right-hand side, you can see my bold yoga, really to yoga, Tai Chi, meditation, all those aspects that are really help manage stress and mood shifts. Or the left-hand side, which is, as we mentioned earlier, different sorts of oils, vitamin E, coconut oil. There's hormones that you can put in. Women with breast cancer can use vaginal estrogen suppositories at a low dose. So there's a company that makes a low dose estrogen that's at 4 micrograms, and that is only provides local estrogen therapy, not systemic, which is normally 10 micrograms. And so for women with breast cancer, this is still an option, thankfully. And then something called Scream Cream, which I'll show you in a moment, a slide of what's in there. Testosterone itself. Testosterone can be used systemically to increase libido. Some women use it topically over the clitoris to increase sexual response, as well as increase libido. So it really has a twofer there as well. And a lot of women use this company, which I'm a very strong proponent of, called Good Clean Love. I have no financial relationship with them, but they really make a lot of very good products. Here's an example of one called BioNourish. They have a few different products that are quite good that women really have given very positive feedback around. The Scream Cream is a prescription medicine that's compounded in a compounding pharmacy. But one of the best compounding pharmacies in my experiences, it happens to be locally here in San Francisco. It's called Koshland Pharmacy. Peter Koshland owns the pharmacy as the pharmacist, and they have a really high quality shop there. So in this is aminophylline, L-arginine, and sildenafil. So really you have here different agents that will all really increase blood flow. This is typically applied around the clitoris area and dramatically increases blood flow there. And you can either do it in the vaginal area at large, but typically you do it around the clitoris and just around outside of that, that really increases sexual response. So I've had many women use this and really come back with very positive comments, hence the name of the product, Scream Cream. So thinking about memory a bit, this is just generic outside of menopause, just in general, but exercise we know is critical. Eating well, reducing inflammation, critical, reducing stress, staying mentally engaged. Supplements at the bottom you can see, and then hormone replacement as we've spoken about. In general, the lifestyle changes, as we've already talked about, relating to exercise, ideally 4 times a day, ideally 30 minutes, but 15 minutes actually has been shown to provide significant benefit. 30 minutes even better. Yoga, there's been a lot of research looking at yoga for hot flashes and for mood stability and sleep as well. So really there's a lot of data around that as well. And then around diet, here's some specific recommendations really about how to eat in a manner that helps estrogen dominance, metabolism of estrogen to its more healthy subcomponents by eating cruciferous vegetables, for example, and then green tea, flax, soy, seeds, nuts, all really trying to eat a robust amount of these types of foods, which many of us do in the Bay Area. And then, of course, as we talked about earlier, we're looking out for these estrogen modulators. The environmental working group, EWG, is a great resource to look at plastics as well as different types of sources for estrogen modulators to try and reduce our exposure. And then what about hormone testing? So a lot of the people like to be tested. I have mixed experience with testing. Sometimes it's not necessary, and sometimes I'll really be with that. Sometimes it is necessary, but for the most part, it's not. And the reason being that for the most part, we go on symptoms. So you're presenting with certain experience in your life of what's going on for you. We then give you hormones and you report back your symptoms. That's what we need to base it on. Sometimes it's helpful because I've had one patient, for example, she was having sleep disturbance and irritability, and she's being prescribed hormone replacement therapy by a different provider, not me. And I encouraged her to get her hormones tested, and sure enough, her estrogen levels were off the chart. She was at 300 when it should have been more like 20 to 40 or 50. And so that explained her irritability and her sleep disturbances because she was being overprescribed estrogen. But in general, we can just modulate that by, I would have known that honestly without having to do the test, but I had to convince the patient that that was the issue. So we got the test and it showed that was the issue. So rarely do you really care about them. For example, you don't use that test to decide if you're in menopause or not, right? The test is a clinical test that you haven't had a period for over 12 months. And or even if you're not in menopause, what about perimenopause? Again, it's not based on hormones, it's based on your symptoms of changes in your menstrual flow, menstrual cycle, cadence, your symptoms, etc. So there is a test called AMH. It does help predict time to menopause. So some women want to know, am I within a year or two of menopause? This test, which had historically been used for fertility, on the opposite side of its spectrum on the score, it can help us predict within 1 or 2 years of menopause. People historically have used FSH to say if someone's typically in menopause, it's less good at predicting menopause. But if you're already in menopause, FSH will sort of show that to you. And then there are companies that do estrogen metabolism testing. And there's mixed thoughts about that. Some people love them because the thought is that by looking at your metabolites, we can change, as I showed before, the 2-hydroxy, 4-hydroxy, 16-hydroxy. We can try and change those ratios to modulate your risk of breast cancer. Some other data has come out saying we don't know if those actually do predict breast cancer, so it's sort of mixed. But in general, some people use that as well. Urine-based and ZRT uses a saliva-based profile. And then thyroid testing, obviously. So some people are presenting with symptoms. We might be fooled thinking that it's actually your hormones related to sex, sexual hormones related to menopause. It turns out it's maybe you have your hyperthyroid or maybe your hypothyroid. So that's sort of a quick list on that, on the hormone testing, since people are typically asking about that. I want to make sure we touched on that. So I think we covered most of these here. What I'd like to do, we're really coming up on the hour. So if there's any questions that anyone has, topics that I didn't cover, I'm happy to entertain those. There is one question here about rhubarb, and someone had some terrible stomach ache from it. That's not typical. Siberian rhubarb is the rhubarb you should be trying, Siberian rhubarb. And I would recommend you try it again, maybe try it at a lower dose. if you're using that for hot flashes. That'd be my recommendation. How about increasing bone density is another question. So we had a slide on bone density a little earlier. There's really nothing better than hormone replacement therapy for bone density. There are sort of composite supplements that, for example, we use Zymogen as a dietary supplement company. They have to have some great products that are helpful for bone density. But I will say they all, and also as well as strength training and using weights for strength training and body-based exercise, using gravity basically for exercise. So running, cycling, walking, hiking. Those are all the things we really try and do. And then estrogen itself is quite phenomenal for that. So, but those are really the range of options that come to mind. I'm 8 years post-hysterectomy, and how do I know if the symptoms are perimenopause or just stress and personality? Kept my ovaries. You kept your ovaries. Okay. So you don't have a uterus, but you do have your ovaries, if I heard just understand this correctly. And that was 8 years ago. Right. So you're not having your uterus would not affect your moods or your hormones. It's your ovaries. So if you have your ovaries, then it really relates to where you are in your menopause journey, how old you are, whether your symptoms have changed outside of menstrual flow, obviously, have changed as it relates to perimenopause. You may want to do an AMH test, depending on your age. Are you 35, or are you 70, or you're somewhere in between? Assuming you're not, below 35, you're greater than 35 and younger than 70, or younger than 60 for that matter, you might want to do an AMH test. That could be helpful to see how close you are to menopause. Well, thank you for your time. I don't want to go over. I want to respect everyone's time. We do this monthly, so please come back, and we will post this up on YouTube for those that have missed it. If you know folks that want to see it, feel free to direct people to Dr. Brad Jacobs on the YouTube channel. All right, take good care and have a good night, and go Giants. Take care. Bye-bye.